Good morning and welcome. I'm Sue Bornstein. I'm the co-lead of the Texas Primary Care Consortium and want to welcome you to our November webinar, Shaping the Future of Primary Care Policy Impacts. Well, I think we can all acknowledge that there has been a lot of change and there will be more change in the legislative and policy environments in the next several years. One thing you can be sure of, that is that the Texas Primary Care Consortium's commitment to advancing comprehensive and sustainable primary care for all Texans has not and will not change. The need remains the same. This morning, we will explore how we can effectively move forward in a dynamic fashion, working with our existing partners and also with new groups. Next slide, please. Thank you. Just a quick review, the Texas Primary Care Consortium, we're a statewide collaborative. Our mission, you can see, and we are co-led by the Texas Medical Home Initiative and the Texas Health Institute. Next slide, please. And how do we do our work? Well, this diagram shows how we approach our work through the educate, activate, and transform model. This has been our framework for the last 6 or so years, and we will continue using this framework for our work going forward. Next slide, please. We want to give a special thanks to our partners for today's webinar. We are very grateful for their assistance and their continuous support and collaboration with us. Next slide, please. Well, it's such an honor and to introduce our speakers today. Tom Banning will be the moderator. Tom Banning is the CEO and Executive Vice President, the Texas Academy of Family Physicians. Tom will facilitate this webinar. Tom is also a former lobbyist and is one of the very best friends and most longtime supporters, he and TAFP, of the work that we do in Texas Primary Care Consortium. Next, Helen Kent Davis. Helen Kent Davis is Senior Policy Associate, the Texas Health Institute. Helen has her own consulting firm, HKD Consulting, and we are fortunate to have engaged her expertise. Helen has a lengthy and very distinguished career as in health policy in Texas, specifically focusing on the uninsured, rural health care, and maternal and child care. And finally, Larry Gonzales. Larry is our legislative consultant. Larry's a 4-time member of the Texas House of Representatives and has helped guide us very effectively. So with that, I'm going to turn it over to Tom Banning.
Thank you so much, Sue. We can go to the next slide. Thanks so much. I'm going to enjoy the next bit of time that I've got with my 2 good friends, Helen and Larry, kind of talking about the political landscape that we're walking into and how that political landscape is going to affect primary care in the next session of both the Texas legislature and Congress. We're also going to discuss opportunities to improve primary care through public policy and offer some insights on how state and federal election outcomes will affect the political process and healthcare overall, with an emphasis on primary care. So let's go ahead and get started. Larry just got done teaching a class on public policy, so he's teed up and ready to go. And
right. That's right.
Having served in the legislature, I think you would agree that on a couple things. One, that politics, drives policy decisions and what the legislature focuses on, and that elections have consequences. So with that, Larry, why don't you take it from there and tell us what we're looking at?
Thank you very much, Mr. Banning. Yeah, the Texas House, we created this slide here for you. So following the elections, the primaries, and then, of course, the general election on Tuesday, we have 32 House freshmen coming. 32. That is a significant number. of freshmen. Those are the kind of numbers you see in a redistricting year, maybe, right? So there's a lot of new members that are coming in. Depending on a few variables, you can have between 12 to 18 new chairmen. Out of 34 standing committees, a third to half of your committee chairmen can change. So the good thing, well, let me tell you, start this way. The tough thing about that kind of turnover is loss of institutional knowledge. The good thing about that kind of turnover is loss of institutional knowledge. We have an opportunity here to educate a whole lot of freshmen what we do, how we do it, why we do it, how it all works. As the members stay for a while, as you all know, we develop relationships across the board. And if you're on the inside, if you're in a good spot, this can present maybe some questions going forward. But if you've been on the outside looking in for a while, this may be an opportunity to get some things done. So the makeup of the body, in the House, the Republicans are up 2. In the Senate, the Republicans are up 1, but that doesn't fundamentally change a lot, the raw numbers. What does change is when you look at the Public Health Committee. Public Health Committee is going to look very different. When you look at Article 2 of the budget, it's going to look very different. You know, a Representative Jeton lost, so there's Stephanie Click. You know, she lost, and look at J.C. Jeton. J.C. was subcommittee chair for Article 2. He's gone as well. Look at Reggie Smith. He lost his race. For Price, my classmate, you know, he retired. You know, Tom Oliverson's running for speaker. The makeup of this body that we count on is going to look remarkably different. So yes, the elections absolutely affected this when, you know, Stephanie, JC, and Reggie all lost in the primary. So the turnover is going to be significant, but look, I really do look at it as an opportunity to teach and an opportunity to advocate. I'll say this, in my opinion, from a stakeholder group such as this, that speaks in a lot of acronyms. I think everybody needs to really rethink their one-pagers, and they need to really rethink what they're saying and how they're saying it, because with these 32 new freshmen, I'm going to have 80 to 100 new staffers, and they've never heard these things before, largely. We're walking in with brand new information, with brand new terms that aren't easy, right? There's a learning curve. So when we look at, in my opinion, when we look at advocacy, I want us to really look at how we explain these things in a way that the freshman class can be of some help and can be of some benefit to us, but we're going to have to step back and really look at how we talk about these things, because that brand new staffer isn't going to know, literally speak our language. They're just not going to. So take the time, rethink kind of how we message, and let's put together something that you can walk into any office, whether it's, you know, our good friends like Donna Howard, or whether it's going to be, you know, a new freshman, that we can still advocate for in our positions and argue what's best for the people of Texas and the health and safety of the people of Texas. But be aware that that message may vary a little bit than maybe it has in the past. With this many new freshmen, this much turnover in chairman, this much turnover on the agents, on the committees that we specifically care about, and even Article 2. I have no idea what Article 2 is going to look like. So those are the variables that I think post-election that we need to navigate, Tom.
Tom, you're on. Tom, you're on mute.
You would think after 4 years of this, I'd learn better, but apparently not. So Larry, we've got a couple more minutes before we kick it over to policy. I want to stay on sort of the political frame, which will help inform our policy discussion. But when you look at nationally what happened with President Trump winning election with the Republicans picking up the Senate and most likely picking up the House. We haven't seen party alignment like that since I believe Obama was in office.
Right.
Obviously, the Texas legislature similarly is aligned. Are they coming in with a mandate? And if so, what are those political mandates that they're coming in to focus on?
There's, without a doubt, the Republicans are very empowered by the results on Tuesday. They feel it is a mandate. They said what they were going to do, and I believe them, right? They ran on it. They said it out loud, and they won. So yes, I think at the state level and particularly federal level, they are empowered to make some bold decisions. So what does that mean for us? I mean, I think you have to start looking at a lot of decisions from the federal government coming to the states. You can look across whether it's healthcare, whether it's education. We can name a lot of different areas of policy where I think they're going to push a bunch of decisions down to the states. There's always been conversations about, of course, now there really are, about getting rid of the Department of Education and just sending down block grants for education. We're going to hear that conversation, I think, possibly coming out of the feds on healthcare as well. There's just going to be a different conversation out of DC. I think we all know that. To the extent that it happens, I think we're all kind of waiting to see. But to your question, they absolutely feel empowered that this is what the voters wanted. This was our message. We won overwhelmingly across the country. This is what we're going to do. So I think we got to start looking for decision making out of DC. And I also think block grants is probably something across different areas of policy that we're looking at, as there's going to be an effort, I believe, to return things to the states. I think you're going to see more of a movement to put the legislatures in charge of a lot of these decisions at the state level. And if that's the case, it makes everything I just said about the state government exponentially more important when all of a sudden the federal government say, hey, look, Texas, Missouri, California, Massachusetts, you guys figure it out. Here's the money, run. Boy, does across the street really, really matter now, right? I mean, more so than it has in the past. And I think it's fair to say we should anticipate that, Tom. I really believe that.
And of course, the only thing that the legislature actually has to do is pass a balanced budget.
Right. Yeah, they got to get the budget done. And look, the House is so unsettled. There's a lot of decisions yet to be made in the House. There will be one decision, or at least one vote on December 7th, rumor has it. And we'll see what that looks like. And then under anybody's leadership in the House, there's a significant conversation around what all this looks like in a leadership capacity. And we just don't know. A lot of bills got filed yesterday. Maybe your bill author is going to be in a great spot next session. Maybe your bill author is not going to be in a great spot next session. So some of those early bill filings, I look at and think, man, I probably would have waited a little bit because we just don't know. We just don't know what all this is going to shake out like. But I will emphasize again, through a state conversation, through a federal conversation, I want to put the positive spin that while there is uncertainty, for sure, there's still an opportunity. There's an opportunity for advocates in Texas to work the body across the street, the state capitol, to still get things done. I just think we need to be ready for some significant changes and message it in such a way that we can be very successful and protect the health and safety of all Texans.
Yeah, and it sounds, what I'm picking up, and then I'll kick it over to Helen, is we're also talking about a much more compact time frame than the typical 140 years that we're in doing, legislation. If you're going to be reorganizing potentially some of the House and House committees before they can get back, get into work.
Yeah, I wouldn't make summer plans. My elected official friends have told me they've already been told not to schedule anything through August. I think there's a lot of work to do, and depending on the federal side of this thing, even more work to do. And 140 days is going to be really, really quick for this amount of changes that we're talking about. And so, of course, the first 60 days, that's still in place as well. So there's not a whole lot moving in a ledge. So do they run out of time to make these kinds of significant changes? They certainly could. But I wouldn't suggest for anybody to be looking at a June retreat with your friends in Colorado somewhere. I am. All of my plans are in September, sir. That's what I'm planning on.
Well, Colorado would be a nice place to be outside of Texas, but I will heed your advice. Let's and we'll circle back a little bit later in the discussion for questions. But Helen, let's transition over to you. Tell us about some of the policy that we might expect, some of the things that the coalition has been working on, or the consortium has been working on.
Thanks, Tom. Thanks, Larry. And before I get started, I did want to just kind of lay a little bit of a context for how the electorate lays out in terms of healthcare coverage and their thoughts. There's certainly going to be a lot of change in the coming 4 years, and I think what's going to be interesting is you do have sort of the people's political affiliations and how they voted, but also how they obtain coverage is pretty split. And that's changed a lot in the last 4 years. And so that also presents opportunities as more people have gained coverage. It makes it harder to make some changes that, could upend coverage for Texans and elsewhere. But this was a poll conducted by the Kaiser Family Foundation regarding people's coverage by their political affiliation. And so you can see it's, of course, Medicaid has, if you look at Democratic affiliation, is higher here. But when, across the landscape, it's pretty split. And that means that when people think about their coverage, while they might vote in a partisan way, how they experience coverage is, they still support these programs. Next slide. And again, this is just another example of the same thing when you look at, people's interests and how they split across the political divide. One thing that's not reflected here in the last 4 years since, Trump was last president and President-elect Trump coming in, more states have expanded Medicaid and more states have seen an uptake in coverage under the Affordable Care Act. So, and that's across, Texas is one of the biggest beneficiaries of ACA, the Affordable Care Act premium subsidies, as was Florida and several other conservative states. And so, whether or not you vote a certain way, does how you obtain care and where you get it, that is important. And people experience healthcare as an economic issue. So if their costs are going to go up because they can't get coverage because they lowered premium subsidies, I think it makes it somewhat harder to do some of the things that the Congress is considering. Next slide, which we'll talk about. And I think this quote from Drew Altman, who's the president of the Kaiser Family Foundation, now just KFF, really kind of encapsulates what this issue is why people vote in a partisan way, how they experience healthcare is, and react to changes will be based upon how they're getting their coverage now. And, recent data from, post-election shows that, while the economy was very important to voters, healthcare costs are a big part of that too. While healthcare wasn't at the top of the list in terms of voter concerns, it's still how people experience the economy in terms of healthcare as an economic issue. It certainly is one. And analyses have shown, just the benefits of, for example, the Affordable Care Act, premium subsidies. It's a difference for a family of 4, earning about 400% of poverty. It's a savings of close to $8,000 having those premiums. So that is a factor going into the next election cycle that we didn't have last time. It's just a growth in these programs. And, people, I think, would be rightly concerned about changes as we move forward with the next Congress and in Texas. Next slide. So this is a slide from America's Health Rankings, and Texas is ranks 39th out of all states. This, of course, was conducted prior to the election. And I just point this out because I think regardless again of your political affiliation, Texans want to be healthy and they want their state to be healthy, and they understand that without health, you can't work and take care of your family. And I think this is also important to lawmakers, regardless of their political persuasion. We've seen that in the Senate here in Texas, hearings on how to improve healthcare access from both primary care and mental health. Some of the interim charges in the House, while there weren't very robust hearings for because of all the losses that we had during the primaries and just recently, as Larry mentioned, there's still a lot of interest in, what can Texas do to make the state healthier? And I think that primary care plays across the political divide because, again, it's something that people experience in their lives every day, or not every day, maybe, every year or regularly, parents taking their children to their pediatrician, or women getting their annual exams, adults getting their annual physicals, and just having that primary care connection. So regardless of what happens with changes, I think primary care is well positioned in terms of talking to new legislators about why this matters to their community. And of course, primary care clinicians and clinics are very active in communities and having that discussion with local legislators, particularly new ones. And also, just thinking about voters' concerns about the economy. Part of that is healthcare costs, which have been rising at a rather phenomenal rate for the last several years. And primary care is, again, a part of that effort to constrain healthcare costs. But I think, regardless of what happens in Congress and what happens here, trying to make the state healthier will remain a high priority because that's just something that everybody can relate to. They have different ways of achieving it. Next slide. So thinking about, the changes that are upcoming, again, I mentioned, in the last several years, we've had really phenomenal growth in coverage under the Affordable Care Act. In particular, Medicaid, we had unwinding, which was a different issue. But since then, many people who lost Medicaid coverage have regained it under the marketplace or the Affordable Care Act. And so that sets up a different dynamic thinking about the next Congress. Incoming President Trump, or President-elect Trump, has really not said what his position is on changes to the Affordable Care Act and Medicare in particular, though, of course, leaders in Congress have talked about substantial changes. But again, I think the electorate, thinking about the potential loss of coverage or an increase in their costs as those plans become more available, might cause people to rethink potential changes. I do think Medicaid is the one where, to Larry's point about shifting the conversation to the state, the last administration of Trump, we did have a lot of discussion about block grants and waivers and changes to how Medicaid operates, and that is certainly going to continue. President-elect Trump has said that he's more inclined to protect Medicare in particular, and that leaves Medicaid out there as a potential area for change. So that is something in terms of a challenge as primary care clinicians think about it, given just the number of Texans who are beneficiaries of the Medicaid program. But that challenge leads also to opportunities and ways in which we can position primary care to be a better and more robust part of Medicaid, which right now it's not. And if we're going to look at controlling healthcare costs, which are a concern for voters and, of course, their elected officials, primary care is well positioned to talk about how some of those changes in Medicaid could be achieved without upending coverage in a negative way. Primary care workforce and mental health, those are issues, again, I think are very much bipartisan. You've seen that here in Texas. The governor had his task force looking at the workforce, particularly it ended up focusing on nurses. There's a report coming out soon on primary and mental health care workforce. And that is an area where people, again, experience it at the local level. They want to see more primary care investments. They want to see access improve. So I don't expect that would particularly change, and there'll continue to be strong interest in ways in which to increase access by expanding availability of the primary care workforce. Now, how that gets done, again, is going to be an area where everybody on this call is going to have to engage about why it's important and why that funding is important. And to Larry's point, I think talking about, in particular, what is primary care, and making it very clear and defining what that means in terms of access. I think, looking at delivery system reform and payment reform, that again is another area where there's been a lot of interest in experimentation, shifting that role to the states about ways in which you can reimagine how healthcare is delivered and how it's paid for so that it's more sustainable. The business community has become more involved in that discussion here in Texas and nationally, and that I don't expect to change. I think what will be a challenge is explaining what value-based care means. We use a lot of these terms and throw them around, but a lot of people don't necessarily understand what value-based care is. Though at the end of the day, we know it's about making people healthier, looking to improve access and curtail costs in a way that's effective. So that will be part of our effort going into next legislative session, is explaining, why primary care matters, but also these new initiatives around whether you call it an alternative payment model or value-based care, what they actually mean and the benefit to Texas for embracing value-based care that has a primary care as its core. Population health. The public health debate is going to be one of those areas where I think primary care will face some challenges, just due to the skepticism in the legislature here and in Congress after the COVID pandemic, and people's concerns about how it was handled and mistrust. But from a primary care perspective, most people out there who have a primary care clinician who is a trusted source of information on healthcare, that's again where primary care can play an important role in continuing to talk about the importance of public health, whether that's looking at getting your children vaccinated, or changes at the population level to make communities healthier, to address non-medical drivers of health, which have also been here in Texas. We've seen interest this last legislative session in investing in ways in which to minimize non-medical drivers of health, which are the factors such as access to healthy food, access to reliable transportation, interventions to affect domestic violence. Those, I think, again, have a base of support that will continue in Texas, and with primary care talking about how those drivers impact not just their patients' health, but the cost to the system, are ones that will have broad appeal. And then lastly, I just want to mention maternal, women, and children's health, setting aside debates about reproductive health. There's still broad interest in making sure that women have access to necessary preventive services throughout their lives. We saw this last legislative session, a continued investment in programs such as the Healthy Texas Women's Program and extending Medicaid postpartum coverage to 12 months. Educating incoming legislators about why that matters will continue to be really important. But I think that down payment on those initiatives, will help with a lot of gains. And I would expect going into this next cycle here in Texas and nationally, that there will be a focus on, how do we provide the services women need, setting aside the debate about reproductive health, which is another conversation. Next slide. I think that might have been my last slide, actually. And one thing I just think also is really interesting that, I'll just say last is, when you look at the national votes, there was a lot of concern in the post-election analysis about, as I mentioned, healthcare cost. And so we're still going to be figuring out what it is that voters want. the economy really resonated with him in ways in which to, help them with obviously inflation and their concerns about insecurity about jobs. But people were also very interested in efforts to improve healthcare within their states. And so it's, I think just because of the changes in the last 4 years with people gaining coverage, that just sets up a different dynamic than we had in the first Trump administration. And so continuing to build on those gains, and including in some very conservative states that have found ways in which to expand healthcare coverage in their own way. I'm not suggesting that it's necessarily going to happen here in Texas, but I do think that just sets up a conversation at the national level that we didn't have prior in the first Trump administration, and will make it a little bit more difficult potentially for Congress to enact sweeping changes that some people might be worried about.
Well, thank
And
you,
also-
Helen. Oh. Thank you, Helen. And I encourage the participants who have questions to go down to the Q&A and put them in queue, and I will do my best to get to them. So, Larry, let me start with you. And I understand. I think that most of the participants probably understand that there's the known knowns and a lot of unknowns. One is what the governor is going to make an emergency item. Who is going to be leading the House, what the committee makeups will be, which will be determinative on who the speaker is. So when do you believe committee assignments will likely get announced, understanding all of those unknowns?
Woo. So, I think those who've been watching know that traditionally, third, fourth week of January. I think my freshman year, it was the first week of February. And then once you do get appropriations, for instance, named, appropriations meets for a good week and a half before you get subcommittee chairman. Because appropriations comes together, everybody puts together their, they rank them, 1 through 3, kind of which subcommittees you want to be on. So even then, as far as Article 2 goes, I mean, it's mid-February before we know who's in charge of Article 2. So it's not going to be a quick answer, Tom. There's a lot of moving parts that are going to take a lot of time to play out. I did go back and look at some research and see that there were some sessions when I was a wee child that committee assignments were coming out days after swearing in. That's not been the practice, at least since I've been there, even as a staffer from like the 90s. It takes a while. And the good news is, look, the Senate's the Senate. We know what it is. We know who the players are. We know where they're going to be. There's a lot of stability in the Senate, right? So we can go work over there while the House continues to kind of figure out what it's doing. But there are certain members you can go to. There are certain members who have these interests. There are certain members who have filed bills in the past. Remains to be seen kind of where they wind up, but there's plenty of opportunities for conversations right now. And actually, if you look at some of the freshmen coming in, if you follow their social media at all, there are some freshmen that have talked about healthcare. There's 2 in particular that I asked personally, where are you on mental health? And they named it their #1 priority. Hey man, I got some Republican freshmen coming in and mental health is a #1 priority. That's a good thing to know, right? So these are the relationships I've been building since last October, pre-primary, because I wanted to know, where do the candidates stand? What are you thinking? And some of the questions I run them through are definitely healthcare, primary healthcare, mental healthcare. And there are some good answers in there. And we can go visit some of those folks and we can share that information. But there's opportunity. There really is. I just think that from experience, the members hear things in a certain way, right? And so you have to say it in a way that particular member can receive it. Does that vary from office to office? Absolutely it does. Even within parties, it varies a lot of times. And so understanding the points for different people to make, that's part of the advocacy work that we have to do. is just learn who's going to receive it in a certain way and which members want to hear this and which members want to hear this. It can be the same bill. It can be the same topic, but different members hear different parts of it differently. And it's on the advocates, it's on us to recognize that and to walk into those offices prepared to have that particular conversation about that particular part of the bill with that particular member. And there's a skill in that, and there's a strategy in that.
Yeah, thanks, Larry. And I appreciate you kind of circling back to the Senate because I think that they will likely get to work a lot sooner than the House. And we also have interim reports that will likely be coming out that will provide us some insight into what the interim committees thought were important issues to focus on. So Helen.
Oh, I just want to interject. I just want to say in terms of mental health, to Larry's point about people's interest in it, we know that a lot of mental health services start in a primary care setting. And so, again, if you're in a local community and you're a primary care clinician or have your practice, just talking about that, not everybody really appreciates the role of primary care and behavioral health services. But, that's where parents often go for their pediatrician, or people feeling depressed or anxious start with their family physician or internist. So it's a good conversation for primary care to be having with incoming legislators and everybody else about the role of primary care and taking care of people's mental health needs.
And Tom, I'll add that everybody, you can have an issue that different people can come to from different angles, right? That these two people may agree on this, but for different reasons. And so part of what we do as advocates is figure out what that lens is, what is their filter. I remember on appropriations in 2013, PTSD for the soldiers was a huge issue. And we put in all kinds of money as appropriators into mental health. And the conversation revolved around PTSD. And I remember turning to one of my colleagues and thinking, this is great and all. We should have done this a long time ago. PTSD for the Republican members was the motivation, right? But quite frankly, it's the same topic that could have been a motivation long before that, right? So the members eventually got there through that filter, through the PTSD. Does it benefit everything else? Of course it does. But the motivation in at least 2013 for us, the conversations was PTSD. So recognizing where we are as a state, recognizing the issues that matter to the people of the state, you can get there and you can get people to agree for different reasons on the same bill. And that's our job.
Yeah. So that's a great segue to Helen. I want to spend just a couple of minutes talking about value-based care legislation because, that is designed part and partial to help move or transition primary care physicians away from the traditional fee-for-service transactional payment model to one that pays for managing populations, for providing better outcomes and higher quality. Obviously, and that can be done in a variety of different ways. You could look at a total cost of care capitation, though in a PPO market, I would never suggest that anybody try to do that. You could look at a subscription fee like direct primary care. You could look at a shared savings model. Do you think that value-based care has the potential to begin to even out or level out the payment differentials that primary care physicians and other primary care providers see compared to specialists?
Yeah, well, that's definitely a lot in that question. So yes, in a word, I do. I think that value-based care has a lot of potential to help primary care practices really just be sustainable in our healthcare system. The current payment model has resulted in many practices just hanging on by a thread, among other factors. But we know that when you invest in primary care, it's one of the few services out there in the healthcare system. You have more of them, costs go down or constrained. So I think the challenge, there's definitely in the last Trump administration, there was some skepticism coming in from the Health and Human Services secretary about value-based care, but that changed. Value-based care really did continue to move forward. And I think that will as well, just because of its role in, and particularly among employers and finding ways to constrain cost. And likewise here in Texas, I think there is growing recognition, not growing, it's been there. We've had value-based care and Medicaid for many years. More employers are embracing it. I think the challenge will still be, what are the resources to help primary care clinics achieve true value-based care? There's still among primary care practices, just the need to invest in, data analysis and retraining your staff and, contracting in a way that makes sense for your practice, which would be different from a large physician group to a small one. And there have been resources put in place for the hospitals, particularly the rural hospitals in that area. So I think talking about how just more holistically to address value-based care, bringing along primary care systems so that they're able to compete in that space will be an area that we need to talk about. And to, getting always back to what Larry said about educating new members, they're coming into this with really just many of them a very basic understanding of healthcare in many ways. So talking about value-based care in a way that is appealing and understandable, and that's part of our challenge is doing that. I think value-based care as a term gets confusing to some people, but at the end of the day, when they understand its goal, which is to have a healthier population, help with the sustainability of primary care, to help constrain cost, it's going to appeal to people across the political divide, and there'll be interest in it. And without it, of course, we know that for many primary care practices, without really fundamental changes in the way they're paid, the ability to attract and recruit people to the primary care profession is diminished. So it's an imperative for us, the stakeholder community, to be talking about why value-based care is important for many reasons, for practices, for patients, and community.
Right.
Tom, let me jump in for a second.
Sure.
Part of the secret sauce is, for me, anecdotal, right? So I'm a member, I'm sitting at my desk, and all these groups come in, all day long talking about all these different topics. And people ask me all the time, but like, what's the most effective, right? Like, what works the most for you and your colleagues? And the answer is always anecdotes. It's anecdotes. Like, tell me a story, right? Show me the person, show me the kid, show me the mom, show me the situation where this happened. I think the white papers and the foundational work and all the think tank work lays a very good foundation, right? Necessary for the role to, like, hey, here it is. But what I wanted was someone to say, and here's the kid from Hutto who experienced this, right? And so in the advocacy work, to the extent that we're talking about all these terms members aren't familiar with, to the extent that we can show an example, tell a story. For instance, did you know that, right? Amarillo, Abilene, wherever they are, that this is the situation. And so, part of the advocacy work that I try to preach is to make it personal for the member. So when I was a member, we did these incredible things with autism, and we passed a bunch of autism legislation, autism therapy, autism insurance coverage for therapy, all these different things. It came from a personal place, because as my son was experiencing all these different, he was 7 when I got elected. When he was going through middle school and high school and experiencing all these difficult things, we fixed it. And I go to Ledge Council. How do we fix this for my kid and for every kid just like him, right? And so that's where it started. It started from a dad's perspective, so that when we go to committee and we're having a very, very difficult hearing, when myself and Ron Simmons and Bennett Ratliff could speak, and Dan Huberty could speak from a position of daddy, it mattered, right? It mattered. And I remember my good friend Tryon Lewis from Odessa, he'd walk around with his nose on tip of his, his glasses, then tip of his nose. He'd look at you like this and came up to me and his hands behind his back, and he goes, Larry, your bill's a mandate. I don't like it. But then he says, but I trust you as a dad.
Yeah.
And the bill passes unanimously, voice vote in the House. But it's the storytelling is my point. It's the storytelling. It's bring me the person, bring me the child, bring me the mom. Like, let's talk about these things in a very real manner. And it sounds easy to do, but not everybody does that.
Yep.
And to me, that's just a critical part of advocacy.
Yeah, I think one of the better stories that I've heard around, moving primary care off of that fee-for-service chassis was a story that a resident told me about a diabetic patient that they had that without fail would show up in the emergency room every month about the same time. Finally, they ended up moving into a risk contract, which meant that they had to do a better job of managing that patient and keeping them out of those higher cost situations. So they sent a couple of residents to that patient's house. Patient was diabetic. They went in and found out that patient did not have a refrigerator, couldn't store their insulin. So, from a timing standpoint, it made sense that once they ran out of insulin, they would, show up in the ER. Well, once they used some money that they'd set aside and bought a $300, little college mini refrigerator, that patient didn't hit the emergency room for 18 months. I mean, imagine that trade-off between that $300 investment that there's not a billable event for or reimbursement strategy for, and transitioning that to the cost savings of keeping that patient out of the emergency room, which was probably around, $3,000 a visit. So, just from the dollars and cents standpoint, in addition to, better patient care, those stories do matter and can be very compelling. So, again, a good transition, and I'm going to throw you a tough one, Larry. How do you have, or how do you message, or how do you have a conversation about improving access and quality while controlling cost without mentioning health equity, which has unfortunately gotten tied into DEI issues, or some things that were not played well during the election cycle?
Well, thanks for the easy question. What I got very good at as a member and kind of honed my skills a little bit was getting my colleagues to get to where I needed them, thinking it was their idea. But that varies from member to member, right? So how I talk to them about A and how I led them down this path, Tom, can be very different for different members. It goes back to the trust and the relationships you have with the body. When Tryon Lewis says, "But I trust you, Larry, as a dad," right? That's important. So maybe there's 5 things we agree on and there's 5 things we don't agree on. I'm the guy who starts with the 5 things we agree on. And you build a relationship and you build a rapport, you get the low-hanging fruit done, you come in, you build the collaboration, you build this conversation around things we agree with. Now, eventually, Tom, we have to get to the 5 tough ones. But I don't lead with the tough 5. I don't start with the tough 5. I need to develop a relationship on the easy 5. Now, those easy 5, what are they? They could be 10 years in the making. There's a relationship there on a variety of things that you're walking into that office, not on the difficult 5s. Hopefully, as advocates, you spent your time on the collaborative stuff, the stuff that we agree on. So, but that takes time. It really does. And hopefully with the people that are watching, they know this. They've been probably in this business for a very, very long time. You know where your relationships lie. You know where they lie. Utilize them. Have that conversation of commonality is the answer to your question before you have the conversation over here. There's so much trust, particularly in this policy, right? You want to talk to me about roads and dams and railroads. Oh, that's important infrastructure. But this topic, this cuts to the core of what we do as a state, which is you protect your people. You protect your citizens. That's the core of what we do as a state. So you have to get there, Tom,
Well, and let me just add, and I think Helen would be great to jump in. I think that that's actually the perfect role for the primary care consortium to play in terms of bringing forward data and let the science take you to the inevitable conclusion where you can talk about cause and effect. If you do this, then this is what the data suggests you will likely see. And being a nonpartisan entity that can draw from unbelievable amounts of data and studies should be helpful in making the case outside of the political arguments that everybody enjoys focusing on.
Yeah, and I just want to build on what you and Larry were saying in terms of those relationships. Of course, if you don't have them yet, it's important to establish them so that, an office feels comfortable calling you about a topic to say, just, hey, I want to bounce this off of you. And maybe in your organization, it's, it could be somebody else that has a trusted relationship with a legislator. It might not be your CEO, but one of your members who has a good relationship. I just remember when I first started out, one of the best pieces of advice I ever got was, probably you have something in common with anybody you're talking to. Might not even be on healthcare, might be something else you care about. And so, establishing a bond or a rapport around something you both have an interest in, maybe it's you both, love horses, or you love, going out to the track, you're, watching, car racing, whatever it is, going to, the rodeo, if you're a true Texan, there's something you can talk about, and that helps to then lead you into a conversation about healthcare. Data is super important. I think from this organization's perspective, not using data just isn't in our DNA, but, to this point of stories, talking about how, I think leading with stories is always really important, because people experience healthcare individually, either, by themselves personally or their family. So having stories about how primary care has impacted their health, but all the things that primary care needs to succeed, which is making sure people have access to affordable healthcare coverage, that there's a sufficient primary care workforce, that the behavioral health and mental health needs of their patients, there's a way to address them in a way that's cost effective and accessible within their communities. Just looking at the cost of healthcare, which of course is affecting everybody, including small physician practices, non-medical drivers of health. We don't want to lead with what that is, but people understand, like, if you, if you have a child with asthma, and the place in which they live is has a lot of mold. If you don't remediate that, it doesn't matter what the doctor does, and the parents do in terms of trying to take their asthma medication. You need to find a way to address the trigger, if you will. And so talking about those as stories at the local level, I think, does make a real difference. And then data, on top of that, makes it even more impactful. But, the first thing, if you haven't gotten to know any of the freshmen that are in your district into the house, it would be to try to start that relationship and make sure they have somebody to call when they have questions to bounce ideas off. Because sometimes they don't want to ask questions in a hearing or out loud because they don't know. But if they know, they can call you and say, okay, I know this person's going to tell me the truth. They're going to give me really honest feedback so I can make an informed decision that will help them be a more effective legislator, and they won't forget it.
Well, I want to circle back to kind of where Larry started, and that is there are a lot of unknowns about what's going to happen nationally, what's going to happen in the state. But I think the opportunities that are there for primary care, simply because we're so foundational to a healthier, happier, cost-effective healthcare system, that we're going to play a role in whatever the system delivery payment comes out of, some changes or no changes at all. And being in that position, being that trusted voice and resource is really what we strive to do. And I think that the policymakers that I've met with, and I've met with a lot of them on the left and on the right, really want options for how to improve our healthcare system. That's an exciting place to be, because I'll be honest, for a long time, despite all of the evidence that's been out there and all of the studies that have been out there and national reports on the importance of primary care, it has not gotten the attention that it probably deserves and needs. And I think we're in great hands with Sue and Ankit and their team. And I think it's going to be up to Larry and Helen and I and everybody on this call to, just keep running forward, knowing that we're going to be at the table and part of that solution. So, Sue, I'm going to turn it over to you. I think I made it right under the wire on time. So thank you guys so much for participating and listening. Nope, Sue, you're on mute now.
Okay, who do I pay? All right. Thank you all. This was a really, really good discussion, and I think really helps us all understand what the landscape may look like going forward. We're so fortunate at the Primary Care Consortium to have such really expert guidance and advice from not just our panelists, but from our collaborators and our partners. And I do want to remind everybody, if you have not yet registered, that we will be hosting the Texas Health Policy Forum Thursday, December 5th in Austin at the Hyatt Regency. And this is shaping up to be a premier event. We will have excellent panelists talking about issues that are really important to us and to all of Texans, including workforce and payment reforms and access to primary care. We have legislators and we have other policy experts. And so we really hope that you can make it and join us there. So with that, I thank everybody for participating. Thank you for your questions. Oh, and last but certainly not least, is please save the date. Yes, we are going to have the Texas Primary Care Consortium Summit. Put this on your calendar, October 23rd and 24th in Austin. We look forward to seeing you, and thank you again for your participation. Thanks.